Hello, everyone. Thank you for joining us for this installment of the Root Cause Coalition's 2018 How-To webinar series. Before we get started, I wanted to run through a few features of our webinar today. All of our attendees will be in listen-only mode for the duration of the webinar. At the end of the webinar, our panelists will be answering audience questions. So if you have questions during the webinar, please type your question into the question pane on the webinar control panel located at the right side of your screen. This webinar is being recorded and will be available for viewing on the Root Cause Coalition website later this week. Thank you all again for attending, and at this time I'm going to turn it over to our presenters.
Great, thank you, Monique, and welcome everybody for joining us on our webinar on how to engage community development as a partner for health equity. My name is Daniel Lau. I'm the Manager of Strategic Engagement, and I'm joined by my Executive Director, Douglas Jutte. And we'll do short introductions of ourselves before we get into our presentation today. Doug, would you like to get us started?
Yeah, there we go. Hello, everybody. My name is Doug Jutte. So as Daniel said, I'm the Executive Director, and I'm a pediatrician by training, as well as a public health professor at UC Berkeley. I'll just stop there because I'm going to swing back to myself.
Okay, and Daniel Lau, Manager of Strategic Engagement. I have a background in public health, but also my work experience spans asset building, economic development, and now community development. And I'm just personally very excited to be able to speak with you all today about the exciting opportunities that we see at the intersection of community development and health.
Let's see if we can move forward one. There we go. So I wanted, that went too fast, a little slow. There we go. So my background, I mentioned, my first job after residency was in a low-income community clinic. And, you know, what's related to our work here today and the work of the Root Cause Coalition is that at that point I had 25 years of formal education and realized that despite my medical training, my residency, I wasn't really prepared to manage the real issues that were facing the families that I was seeing. I didn't yet know, this is almost 20 years ago, the language around the social determinants of health wasn't really present yet. And I took a leave of absence to do a public health degree and then followed that with a postdoctoral fellowship in social determinants of health and population health. And it was through that time that I had the opportunity to get to know the community development sector, the Federal Reserve System, many of the players that we'll be talking to you about later. And what became really clear then was that the work of the community development sector, these are the folks who build the grocery stores and the food deserts and the affordable housing and the community facilities and supportive housing for the elderly and the homeless, were creating health through the work they did. But those of us in medicine and public health didn't know about their work. And so the way we think about it at the network is that there's a health ROI, a health return on investment to the work that they do. But that too often our sectors don't know about one another. We don't measure the health impact very effectively, or if at all, and we most certainly don't pay for the work that they're doing. And so today we're going to be talking about what is the community development sector and how we can all work together. So you can see here, these are the sort of ways, we're funded by the Robert Wood Johnson Foundation. We're about 4 years old now, and you can see the ways in which we've been working to cross sectors, connecting partners, providing access to research and best practices, highlighting the health-related value of the work, and encouraging measurement. So today, let's see, we're a little slow, there we go. As I mentioned, we're going to talk a little bit, and I'll go through this very quickly, sort of the problems that we're facing. Daniel's going to discuss, or we'll discuss what is this community development thing we talk about. Then I'll switch over to Daniel, and we'll talk about different approaches and different financing mechanisms, and end with some resources that we have and ideas for next steps. So this is familiar to everybody on our call today, but you might remember the McGinnis, Russo, and Nickman article back in 2002 that highlighted the fact that premature death, only about 10% of premature death is related to healthcare or lack of healthcare. In fact, the predominance was really around other factors tied to where you live and the choices you have available to you. And I'll point out here that the genetic predisposition, the darker segment at the bottom, this is before we knew about epigenetics. And we now know that a good portion of what was considered genetic predisposition then really is tied epigenetically through behavioral patterns and social circumstances. So it only ties even more completely to the neighborhood. Another factor that we all know is the issue of the gradient in health across income. And what we have here is the percent of adults in poor health on the vertical axis and 3 sets of columns by race, Black, Latino, and white. And what we see is a dramatic gradient across income levels. The bars on the left of each section are less than the federal poverty level. The orange is up to 200%, the yellow up to 400%, and the gray is over 400% of the federal poverty level. What we see is the dramatic gradient by income. But what's important is that happens within each racial group as well. There are important differences across racial groups. For example, if you look at the green lines or the turquoise lines for the Black non-Hispanic on the left at 24% and white non-Hispanic on the right, that 3% difference is actually a 14% increase among African Americans for poor health. So there's important distinctions there, but within races, you can see the importance of income. And the reason that matters, our next slide shows that poverty is concentrated. This we also know, but you can see here, this is the percent of people living in poverty by race. All persons on the left and children on the right. And you see a doubling of Latinos and African Americans living in poverty and a near tripling of children of Latino and African American descent living in poverty. And that plays out in important ways. These families and individuals living in low-income neighborhoods where they tend to be concentrated as a result of history of discrimination and structural racism get sick because of their physical environments, their social environments. Many of the things listed here are the very social determinants that Root Cause Coalition is interested in. And this then leads to the often used, your zip code is more important than your genetic code in determining your health and life chances. And we have a few maps many of you may have seen, but it's worth reiterating that zip code can determine your life expectancy. And here you see these are life expectancies in Washington, D.C. based at different subway stops. So metro stations are tied to different life expectancies, as much as 7 years, for example, from downtown to out into Montgomery County on the Red Line. Even worse is New Orleans. Here you can see in central New Orleans, this is right near the housing projects near the French Quarter, 55-year life expectancy. And only 3 miles away, closer to Lake Pontchartrain, is a life expectancy of 80 years. That's a 25-year gap in life expectancy in just 3 miles. It's worth remembering that life expectancy of 55 is similar to Bangladesh or Afghanistan. So these are not inconsequential. The Washington, D.C. and New Orleans are also kind of complicated cities. They are particularly complicated racial history, some issues of governance. This is a map of Minneapolis, St. Paul. And what's striking is Minneapolis, St. Paul, many people think of as one of the better run cities in the country historically. Its equity is high on their list, and health is quite good there. And yet still in the lower left, you see only 3 miles apart, 2 exit ramps off the freeway, life expectancy gap of over 10 years, up to 13 to 15 years. So remarkable differences. In fact, when Robert Wood Johnson Foundation put out these maps, the local TV station interviewed a guy at the lower left exit ramp, the red one, and said, well, what do you think about this map? And he said, well, I think I want to move 3 miles away to the other exit ramp, which really gets us to sort of what we're talking about today, which is the importance of place. And here are 2 maps side by side of Los Angeles County, and these are heat maps. So the darker the color, the worse the situation. And on the left is a map of economic hardship by city. Now this is information the community development sector, the Federal Reserve, the banking sector would be interested in knowing. This is where they would focus their attention and their investments. On the right is childhood obesity by city, which is where public health might focus or the medical system might focus. And yet you can see they're effectively the same maps. The way we think about it at the network is that we've been working in the same places, often with the same people, and yet we don't know one another. And that's part of what we're hoping to change today. And we say this by saying that community development is in the zip code improvement business. So where are we now? The big problem now is that we are spending $3.5 trillion per year on medical care. And as we know, very little of that is spent on public health, as little as 4 to 7%. That $3.5 trillion, 80% of it, actually 85%, I rounded down, is due to chronic disease. We know that most chronic disease is preventable, and we know that most chronic disease happens to low-income people living in low-income places. If you simply calculate that out, what you end up with is a full $1 trillion per year currently spent on avoidable chronic disease occurring in low-income neighborhoods, the very neighborhoods where our colleagues in community development are investing in order to improve the fabric of the neighborhoods. All right, so now I'm going to turn it over to Daniel to talk about what is community development.
Thanks, Doug. So seeing these problems is really, really challenging, but we feel that there's a lot of hope and proof that through cross-sector collaboration and neighborhood investment that can improve the health of residents in low-income communities and communities of color. So I'm going to spend the next few minutes talking about the community development sector and discuss that it's a sector, and I think that's an important point to highlight, that it's its own sector with organizations, policies, and funding, because community development can often be confused as a set of activities. So we'll break down how community development works and how they can serve as an action arm for addressing the social determinants of health and a partner in achieving health equity. So it's important to note this slide talks about we'll open with the past, and it's important to note that when we talk about community development today, it is distinctly different from practices of the past. So what it is today is not what was known as urban renewal in the 1950s and 60s, which involved large-scale public housing and redevelopment projects like Pruitt-Igoe in St. Louis, Missouri. Interestingly, it's worth noting that this 5,800 unit housing development was designed by the same architect of the former World Trade Center. Projects like these were common in the 50s and the 60s when poverty alleviation efforts often focused primarily on the development of public housing, often in isolation of other necessary social supports. But however, this approach proved to simply not work in addressing poverty, and Pruitt-Igoe and most of its counterparts nationwide have since been demolished. So what are we talking about today when we say community development in the zip code improvement business? We're talking about housing that's coordinated with services for low-income and previously homeless populations like these. On the left, you see Solara, a development in San Diego, where the residents' homes are fully solar powered. In other words, there's no electricity bill for the residents. On the right side, you see the Plaza Apartments in San Francisco. Residents of this development have access to key support services that include job training and placement, healthcare resources, social services, and more. Community development is also zip code improvement with comprehensive youth development. So this includes things like the development of charter schools and varied services for children and youth, such as you see on the left side, and then on the right side at Neighborhood Centers, Inc. in Houston, there's a family health center, early childhood education, and a wide range of other community-based and public sector solutions for healthy communities. One more set of examples, it's also resident-focused, community development is resident-focused economic development. So in addition to these projects, there's economic development strategies that include small business development and broader commercial revitalization to help spur economic development and revitalization within communities. So again, citing the Baker Ripley Center, which is based in Houston through Neighborhood Centers, and then the Market Creek Plaza in San Diego. So when we talk about the community development sector, how much money are we talking about and where does it come from? As a sector, annually, community development invests over $150 billion directed into low-income neighborhoods. The greater extent of those dollars come from something called the Community Reinvestment Act, or CRA, which I'll get into in a bit. And then the other various sources are different federal and state tax credits and grants that you see listed here. But let's take a closer look into the Community Reinvestment Act of 1977. This policy was enacted to prevent redlining, which, if folks on the line don't know, the redlining was the intentional disinvestment of low-income communities and communities of color that was very common in the first half of the 20th century. CRA counteracts redlining and specifically requires banks to invest in the communities that they serve, including low to moderate income communities. CDFIs, which we'll also get into a little bit later, which stands for Community Development Financial Institutions, serve as the main intermediary between the banks and low-income communities that broker the investments in housing, grocery stores, and et cetera. And another thing I'll note is that if you think back to the heat maps that Doug presented about economic hardship and also childhood obesity, and you overlaid that with these redlining maps from decades past, it's likely that these would be the exact same maps. So the same communities that have been intentionally disinvested in and discriminated against when it came to financial lending and capital, these are the same communities that are now segregated and also suffering from economic hardship and poor health outcomes. So let's spend a minute talking about who some of these players and institutions and organizations are within community development. So the first group that we'll talk about are the community development corporations and their affiliates. So again, this is another important point, another important place to emphasize that community development is not just a concept or a set of loosely affiliated practices, but a sector that involves the development and financing of everything from affordable housing and grocery stores to services that support residents. And it also includes the leadership of a large network of organizations. So CDCs, which are not to be confused with the CDC, which we're all familiar with in the public health field, are neighborhood level nonprofits that develop the affordable housing facilities and other community development projects. And I'll also take a moment now to quickly highlight that one of the tools that we'll go over closer to the end of our presentation is an online tool that we produce called the Jargon Buster. So we know that in doing cross-sector collaborative work, there's a lot of jargon and industry terms and acronyms that are maybe unfamiliar. So as a great tool and a way to help bridge common language between practitioners across different sectors, we've developed a Jargon Buster to help demystify and explain what those terms are. And the CDC is a great example of that. So we have community development corporations as one of our Jargon Buster terms. So quickly to note, there's over 4,600 CDCs nationwide. And just as one cool metric of their impact, they create about 75,000 jobs per year through their activities. Similar to many major industries, CDCs have trade associations, and you'll see on the bottom of this slide a logo for NeighborWorks America. There it is, which is the National Trade Association for CDCs. And then what we've listed here are other CDCs that are based here in California and LA and the Bay Area as examples. The other large group of players to mention are the CDFIs. These are the Community Development Financial Institutions. CDFIs are nonprofit banks who are financing the efforts of CDCs. There are almost 1,000 CDFIs that are certified by the U.S. Treasury's CDFI Fund. So it's an official Treasury designation that they go through a very robust process to become certified. As one example of their many impacts, CDFIs have contributed to financing 1.56 million square footage of healthy food retail. Unlike CDCs, which are generally on the neighborhood level, CDFIs largely operate regionally or nationally. Two of the large major national CDFIs are LIFT, the Low Income Investment Fund, and LISC, the Local Initiative Support Corporation. A good starting place to find your local CDFI is the Opportunity Finance Network. OFN is the trade association for CDFIs and a really great resource to learn more. So also of important notice is to talk about community development in the leveraging business. So this is going to be a very simplified and hypothetical scenario, but it gets the point across. So, and another way to think about it is it's very similar to financing a mortgage, opening a mortgage for financing your home. So let's take the example of a nonprofit that's trying to build a new affordable housing development. It may start with raising $15 million raised in a capital campaign. So now you have two choices. You can use all $15 million of that to build this affordable housing building, and you'll get a $15 million housing development, a brand new, shiny, high quality, safe, and affordable housing development. Or if in this leveraging example with community development, you can use $5 million of that $15 million in the building and use it to leverage that and finance an additional $15 million from very low cost loans managed by a CDFI and its partners. So through this example, you would then have $20 million in this high quality, safe, and affordable housing development, and an additional $10 million that an investment that you could then put into an early childhood center. So again, this is a very simplified and hypothetical scenario, but it gets the point across that community development is in the leveraging business and can maximize impacts of investments, which is a key asset that it can bring in partnership to public health and health equity. So I will pass it back to Doug now to walk us through some holistic approaches to community development and health.
Yeah, thanks, Daniel. So I know that's a lot to wrap your heads around so far, but now we're going to show some pictures of real life places. Let's see, so we're going to start with an organization called Purpose-Built Communities, and this is a photograph of Eastlake Meadows in Atlanta, Georgia, back in the 90s. It was known as Little Vietnam at the time, not because there was anyone there of Vietnamese descent, but rather that it was a war zone. Only about half of the units were inhabitable, the rest were too decrepit to live in, and it had some of the highest, like I think it was 5 times the rate of murder and violence there. The children were doing terribly. Only about 3% were graduating from school. Well, 3% were reading at grade level, sorry, and only a handful of the adults were employed. So yeah, here's just another photo. It looks familiar if you've been in what used to be called the projects. So the Purpose-Built Communities approach was novel at the time. They settled and focused in on this one neighborhood. So they use a model of a defined neighborhood with 3 pillars. They focus on creating mixed income housing, so replacing the existing public housing with mixed income housing while retaining all the units of public housing, and adding additional affordable units that are subsidized using some of the tax credits that Daniel mentioned, as well as what they call market rate units that allow folks who can pay market prices to move in. They also focus on education from childhood through college, as well as community wellness. And community wellness is things like bank branches and places to play and grocery stores and other services. And what they call the secret sauce in this is a community quarterback. And the community quarterback is a very small, usually new organization, a nonprofit with as few as 2 to 3 employees, whose sole goal is to align all the different resources, investments, existing services for the residents of this defined neighborhood. And in my mind, it really addresses one of the limitations of a traditional public health, programmatic public health approach, which can actually increase disparities. If you provide a program to a community, only those who are most able to take advantage of the program will be able to, leaving the others behind, which can actually worsen the situation in terms of disparities. With the community quarterback, they would note those who were able to get into those programs and identify additional tools and resources to make sure that doesn't happen. So here we've got a few pictures of what it looks like now. So these are actually my own photographs. So this is the housing, mixed income housing by unit. So market rate, affordable, and public housing is mixed unit by unit, or home by home, as they like to say. Here's the recreation center for everybody with the housing in the background. And this is a photograph of the new middle school and high school. It's a charter school. The city of Atlanta was not interested at the time in building a new school there, so they went around them and built a new charter school. And actually this year they just graduated their 2nd class of students that attended the school from preschool all the way through high school. So the neighborhood is about 20 years old now. And for the 2nd year, they had a 100% graduation rate and a 100% college acceptance rate. And these are kids that are about 80% free and reduced lunch, with the majority still being low-income African Americans. Here's a picture. This is me when I visited. That's Danny Choi on the left is the president of the East Lake Foundation, and Shirley Franklin in the center is the former mayor of Atlanta, the first female African-American mayor of Atlanta, who is now chair of the board for purpose-built communities. And just to drive home that this is not a one-off, this is their network site in New Orleans. This is called Columbia Park. It's on the site of public housing that was destroyed by Hurricane Katrina. So in this case, there was displacement, but displacement by the hurricane. And some of the residents were able to return, but many had settled in Houston and elsewhere. But again, this is a mixed income neighborhood with resources. Again, this is public housing, which is pretty incredible. But also, again, if they make it nice enough so that local residents of New Orleans want to move in. And this is actually, you can see these are the old public housing buildings. Part of the financing, it's a little slightly strange, but part of the funding to redo the neighborhood came from a program called Hope 6, a federal program that requires that at least 2 buildings of the former housing projects be preserved to give a sense of place in history. And then what they did in this case is they turned the former public housing into the Educare preschool. That's available, not only available to all the local residents, but they get first dibs. The other example I wanted to give, which is another great example nationally that we found, is called Hope SF. I mentioned earlier the Hope 6 program. That was a federally funded program to convert public housing, dilapidated public housing in the United States, into mixed income housing. And Hope SF, so that funding was discontinued in the early 2000s, and San Francisco was unhappy with the fact they still had 4 large public housing projects left. The Hope SF project tackles those projects while also building on the Hope SF's or Hope 6's successes and failures. And one of the big problems Hope 6 had was by tearing down the entire community at once, there were very, very high levels of displacement. The Hope SF effort is actually tearing down and rebuilding the neighborhoods piece by piece so that all the residents can stay in place throughout the process and no one is displaced. So here's just a picture from the website focusing on the remaining public housing projects in San Francisco. And I have a few photos. So this is the Potrero Hill neighborhood. You can see the public housing at the bottom, the bunker style housing, sort of slotted into the rest of the neighborhood. And you can see downtown, it's quite well positioned. Downtown San Francisco is just off in the distance. This is the new plan. So what you see is the street grid is recreated and a series of city blocks are built that have internal courtyards that are protected so the children have safe places to play, and it prevents sort of criminal activity from having a place to act. The other focus is that these will be townhomes, so that individuals living there will be opening their own door to their own apartment, which is important. They found with the public housing that you'd be walking into a building or into an elevator not knowing who was going to be on the other side. So this is what it looks like now. And I have a couple pictures of what it will look like later. So here are the new townhomes with the cityscape. They're putting in parkland, farmers markets, gardens, and a community hub, which will have a YMCA, a grocery store, assisted living for the elderly on the upper left, a preschool. So many of the things that one needs to build a safe and healthy neighborhood. So very quickly, so those are sort of the large-scale efforts that are increasingly common, but I want to talk about a couple specific examples of the types of investments that are possible. And I'm going to focus on healthcare examples, given our audience here. There's very few of them, but they are exciting and I think show us a path forward. So this is the South Philadelphia Community Health and Literacy Center. It was spearheaded by the City of Philadelphia in partnership with the Children's Hospital of Philadelphia. And what's interesting, it was actually CHOP, the Children's Hospital of Philadelphia, that was able to receive the New Markets Tax Credit. You see that in the lower left. The New Markets Tax Credits were one of the federal tax credit systems that Daniel mentioned briefly earlier. This is money that's focused on job creation in low-income neighborhoods. This is a community that has really struggled. It's one of the red line neighborhoods of Philadelphia. And what the city and the hospital realized was there was a plot of land with a rundown recreation center, and a rundown community clinic on site, and a rundown pediatric clinic on site, actually, that the Children's Hospital wanted to redo. And by partnering, they were able to take all of that space at once and create a joint building that is a library, a recreation center, a new public clinic for adults, and a new children's hospital clinic for children. Another example, which is really fascinating, so Dignity Health is formerly the Catholic Healthcare West. It's now the 5th largest and soon to be potentially the largest healthcare system in the country. They're merging with another Catholic system. They're based out here in San Francisco, but function nationally. They're one of only a handful of hospitals that have a loan fund. So they have $120 million. This is out of their equity investments. That is designated by the nuns to invest into community infrastructure for the betterment of local community health. In this case, they invested in the Children's Museum of Phoenix. They provided the last couple $1 million to close the funding gap for the building of the new museum in South Phoenix, again, a historically marginalized neighborhood. And the museum is now a hub, sort of an anchor for additional growth in that neighborhood. There's a couple other examples, or the Trinity Health, another large Catholic healthcare system based in Michigan, similarly has a $75 million investment fund. And here's an interesting example of another healthcare player that I think we sometimes don't think about enough. United Healthcare is the largest for-profit health insurer in the country. And in Phoenix, it's funny that it happens to be 2 Phoenix stories. I spoke in Phoenix, and the people there were super excited about that. United Healthcare partnered with Chicanas por la Causa, a local CDC, a community development corporation, to provide the funding to purchase 2 large housing units. And this is what was called naturally occurring affordable housing, or NOAH, N-O-A-H. And NOAH is important because these are affordable rental units that are often in bad parts of town and not well maintained. In this case, these 2 buildings, or these 2 complexes, were a total of 500 units or homes, apartments, that using the money that United Healthcare provided, $20 million at less than 2% interest, they were able to purchase these 2 properties, rehabilitate them, and then provide them back to the community as affordable housing that was managed by themselves, by the CDC. So their focus was on their own community members. As a result, the crime in those communities, in those 2 neighborhoods, dropped substantially. And United Healthcare, interestingly, as part of the agreement, has first rights to 100 of the 500 units of affordable housing for their own members. And in Phoenix, United Healthcare is the Medicaid provider, and they were most focused on housing their homeless Medicaid recipients. And so they're able to use those units to save themselves and the healthcare system substantial amounts of money, which helps make it affordable, or makes the investment of the $20 million at less than market rate a reasonable prospect. Another interesting example, this is, of course, this is you guys, or Root Cause Coalition. This is in Toledo. So most of you probably know, in March of this year, LISC, one of the big CDFIs, the Community Development Financial Institutions that Daniel mentioned, partnered with ProMedica to create a new $45 million investment loan fund for Northwest Ohio and Southeastern Michigan. So again, this is partly hospital dollars, partly LISC's resources, and a substantial effort to raise additional funds. But all of this money will be focused on the sorts of community investments that we've described. And following on that, actually I've got one more, and then there's another last one. So another great example, and this one's a little bit more complicated. It sort of falls between the one-off investments that we've been showing you and the holistic investments. So this is called the Conway Center in Washington, D.C. And this is a $90 million investment in Northeast Washington. So again, a historically disinvested neighborhood that addresses multiple social determinants of health at once. About half of the funding came through something called the Healthy Futures Fund. The Healthy Futures Fund was formed by LISC, the organization I mentioned a moment ago, the Kresge Foundation. The Kresge Foundation It's based in Michigan and is derived from the Kmart wealth, the Kresge family, and Morgan Stanley, a for-profit bank. And the Healthy Futures Fund is a $200 million loan fund that provides resources at cheap interest rates for efforts that are putting housing, affordable housing, adjacent to or in the same building as clinical care. So in this case, the Conway Center, which is just about to open, is a combination of 200 units of affordable housing, half of them reserved for low-income families and half of them reserved for local homeless single individuals who tend to be the hardest to house because a lot of programs don't work with them well. They also have a job training center run by a local faith-based organization called So Others Might Eat. Some is what they go by, SOME. Some actually led the entire development. There's also retail space. You can see there's green space on the roof that's private for the families and individuals living there, and they're across the street from one of the subway stations. So you can get a sense of the ways in which addressing multiple social determinants of health can really build on one another and have a positive impact on that neighborhood. And I think the last piece of this section is a brand new slide. So we just put this in. Many of you may have heard Kaiser Permanente just last week, in partnership with one of the other large community development financial institutions called Enterprise, announced a $200 million loan fund that's going to be focused on building affordable housing. And similar to Dignity Health, this is not coming out of their community benefit dollars, but rather is coming out of their investment dollars. So a small bit, this is like 2 or 3% of their investment portfolio, will now be focused on providing the types of low-interest loans with a return. So they will actually get a return on this investment. It's not a grant, in partnership with the CDFIs and CDCs to provide low-income housing for communities across the country where they have healthcare, where they provide healthcare. And I think you'll talk about these. So I'll turn it over to Daniel, and then we'll wrap up.
Yeah, so I know that was a lot of information, and we've gone over kind of a lot of different examples and organizations and different funding opportunities. So we're going to take this portion of the presentation to kind of close out and also take a deeper look at some of the resources and tools that we provide as the Build Healthy Places Network and ways that we do support this cross-sector work. To start us off, our website is a great place to get connected and to kind of a central hub for all of our tools and resources. So just as an example, some of the things that we offer are an expert insights blog series where we work with local leaders and local stakeholders to kind of talk about the exciting cross-sector projects that they're working on. We have a series of case studies called Community Close-Ups that build off of some of the examples that Doug mentioned that are a holistic and neighborhood revitalization work that address more than one social determinant of health. We host quarterly Network Commons live discussion series where we recruit and present a panel of cross-sector leaders to come talk to us in a Google Hangout live video conference format. And actually our next Network Commons is coming up on June 12th in just a week and a half, and so we can follow up with you for that information. We're going to be talking about our healthcare playbook, which is a new and exciting resource that we've put together that really outlines what are ways that we can make the case and continue to build the evidence base to talk about this health return on investment and strategies to engage stakeholders. And then we also publish a monthly newsletter series called The Pulse, which you can sign up for on our website as well. I mentioned this earlier, but here is a snapshot of our Jargon Buster. So again, thinking about cross-sector collaboration and a lot of different acronyms and alphabet soup that takes place within each industry, we took it upon ourselves to create this Jargon Buster to break down some of these acronyms and really make them understandable and digestible to help build common language and build bridges between sectors. So again, pulling out the example of the CDC, Center for Disease Control for Public Health folks, and then CDC's, Community Development Corporations for community development leaders and practitioners. And so we have a number of definitions, and we encourage you to take a look. If there's other terms that you'd like to see busted, please let us know. Another resource we provide is a publication series called Crosswalk Magazine. So this is a gathering place for stories that illustrate community investment that create neighborhoods promoting health and well-being for all. This is a distinction between our blog series and other case studies, because these are long-form journal articles that really take a deep and comprehensive look at different topics and different issues at this intersection. So from the slide here, you can see that we focused on gentrification, investment, social impact bonds, and different pay-for-success models, and treating the ill to preventing the illness, which took a focus on healthcare investments. And not listed here, but we also have essays on children's hospitals and Catholic hospitals that I think would be of interest for you all. Another tool we want to highlight today is our partner finder. So again, this was referenced when I was talking about the CDCs and CDFIs, that there are trade associations that are useful membership-based organizations to help find who are those local partners that would be in your area that you could reach out to. So this is, I guess in a most simple way to describe it, it's a directory of directories. So what we've done is compile other national trade-based organizations and membership-based groups and compiled them all here so that it's very easy to find if you're looking for your local CDC or your regional CDFI, and even vice versa too for your local health department or the Federal Reserve Bank that serves your region. We've developed this partner finder as a quick and easy way to find who are the partners in your area. So I'll pass it back to Doug to finish us out and to say some closing remarks before we have Q&A.
Yes, we're basically done. So this is just coming back to the network and our vision of equitable communities where all children and families can live rewarding and healthy lives. And the way we go about that is we're now really focusing on the role of healthcare in enhancing the types of investments that can improve people's lives. So we're working to accelerate the flow of the healthcare dollars, efforts like Dignity Health and Kaiser and ProMedica in reaching into the communities using other aspects of their sort of social capital, physical capital, financial capital, and political capital. We identify and speed and spread innovative solutions that we've seen across the country, all with the goal of driving these new cross-sector investments with a focus on creating equitable and healthy communities. So with that, one last thing. So this is just to close. I wanted to give you a quote from Risa Lavisa-More. Many of you may know she's the recent past president of the Robert Wood Johnson Foundation. And 2 years ago, we helped bring her to speak at the National Community Reinvestment Act conference. So that's the CRA conference that helps the banks better invest the hundreds of billions of dollars that they're expected to do. And she spoke on the closing panel and said this: "We're likely to look back at this time and wonder why community development and health were ever separate sectors." So this was a speech to 1,500 bankers, and you could see the looks on their faces, like, how is this head of a health foundation telling us that we're in the health business? But I think we've made a lot of progress, and they really do see themselves in this work. So here's some contact information for us, and we thank you all for your attention and your attendance, and are looking forward to following up now with any questions, and certainly reach out to us later. So thanks very much.
Great. Thank you so much. Really appreciate everything that you guys shared now. Just want to remind our participants that if you have a question for Doug or Daniel, please feel free to write it into the question pane on the right side of your screen. And I will give everyone a few moments to do that. And while that's happening, I just want to remind our participants that a recording of this webinar will be available for viewing on the Root Cause Coalition website. An email will also be sent out to all the participants to let them know that it's up, and the slides can be downloaded as well.
If we have an additional minute, I can jump in with something that I realized that we didn't explicitly mention during our resources and tools is that for us as a network, we also have a growing advisory services and technical assistance arm. And so I know we mentioned a lot of tools on our website and different events and activities to get involved in, but if folks are looking for kind of more personalized and just to have more custom and tailored conversations about what cross-sector collaboration really looks like for them in your local context, that is also something that to feel free to reach out to us about. We have a growing program area to be able to provide technical assistance and advisory services, and so we'd be happy to have conversations with folks about that.
Daniel, and I think that was a wonderful segue to our first question, which one of our participants are asking either of you if you have any tips for successful multi-sector, cross-sector partnerships, and looking at these partnerships, what have been some common pitfalls or roadblocks when trying to engage cross-sector collaborations?
Yeah, that's a big question, but an important one. In terms of sort of anyone who's interested, I would suggest as sort of a first step would be to, I know it's hard to find the time, but we've tried to make our case studies, the community close-ups as we call them, very readable and provide some of the details around how exactly these co-investments occur, where did the resources come from, what was the initiating event, who led the efforts, some of those types of details. There's also a lot of worthwhile information, and again, written in those essays on the Crosswalk magazine are written by journalism colleagues of ours. They're very well written. They provide detail, but they provide it in a way that's very accessible. And I think it can start to give you a sense of, by reading those, thinking about your own community and potential partners, how could you not replicate, but build on what's been done elsewhere. And I would say the most important thing to do, and this is something Daniel mentioned a couple times, is that simply reaching out and saying hello and calling the organizations, identifying which of the CDCs, the Community Development Corporations, work in the neighborhoods where your hospital or clinic work would be an important first step. Finding out whether there are any local CDFIs, the Community Development Financial Institutions, or offices of the national CDFIs that are in your city or your community. As we said, there's over 4,000 CDCs, so there's almost definitely one nearby. Call them and actually set up a meeting just to sit down. And that's something that we can certainly help you think through how to do that. But it also, we find this on the community development side, because we give a similar talk from the flip direction. It's just simply having an initial conversation to hear where they are making their investments, what's in it, what they call their pipeline, where are the future investments that they already have in the works. Do any of them overlap with the work of the hospital or in the neighborhoods the hospital is worried about? Or similarly, from your perspective in public health or in medicine, where are the neighborhoods that you're most worried about? And are the local CDCs and CDFIs actually focused there? They probably are, but if not, it may be an opportunity to shift where their investments go. So that initial conversation, it can sound a little silly, but the thing I have found as a physician actually most reassuring is that universally, these organizations and their leadership are thrilled to have a call from someone in public health or medicine. They don't always know what to do with you initially, but they are excited to have a conversation to see where the overlapping interests are. And once you identify overlapping interests, they are experts in identifying financial resources to help make those changes, which is, again, I think an important part of this work is they have at their disposal billions of dollars of resources. Now, it is, so to the other second half of the question, the pitfalls, I think there are a couple important pitfalls. The timeline of community development investments tend to not line up well with the needs of the healthcare system. It can take years to get affordable housing built, for example. It can take years to get a grocery store put in. But if you don't start now, it won't happen later. Another issue is the expectations around a return on investment. we all know how hard it is to measure health and to measure changes in healthcare status. The types of investments we're talking around grocery stores, around supportive housing for the homeless, around affordable housing, can be very difficult to identify short-term wins. But we know that these have long-term impact. And so there's a timeline issue. There can be a geographic issue. Hospitals' geographies tend to be wider than community development. They focus in on individual neighborhoods or a single city block for a building, which can feel like they're not having the kind of impact that a hospital might be looking for in terms of its emergency room visits or its hospitalization rates. But again, if we don't start now having these conversations, we won't change those healthcare utilization patterns in the future.
Thank you. Yeah, and I think you spoke to this idea, Doug, that when we're engaging in cross-sector partnerships, it's important that all of the sectors come to the table and understand each organization's motivational factors towards engaging in partnerships.
Mm-hmm.
So
Absolutely.
Another question that a participant had was based on when you were talking about where are we now and inefficient investments, and you cited a $1 trillion per year number on avoidable chronic disease occurring in low-income neighborhoods. And one of our participants wants to know what that $1 trillion is being spent on. Just like
that's simply my own calculation based on the literature. So again, 85% of our $3.5 trillion a year is spent on chronic disease. And if we know that most chronic disease is avoidable. So if we take 50% of that, and then we acknowledge that a lot of chronic disease, we'll say half, is happening among low-income people who tend to be concentrated in low-income neighborhoods, you come out with a little over $1 trillion being spent on avoidable chronic disease in low-income neighborhoods. So that's all of the chronic disease that we see that's causing the shortened life expectancies in those zip codes, in those neighborhoods. So it'll be the type 2 diabetes, the obesity, the heart disease, the simple, the simple aging that we see among folks who are constantly experiencing the stress, the toxic stress of growing up in these low-income neighborhoods. And, those of you who have already done some of this work, a fair amount of this, unfortunately, of the toxic stress that children experience is embodied. It is mediated through biological changes in their immune systems, their hormonal regulatory systems, through their neurological response to stress systems, and those lead to higher rates of chronic disease over time. And so that's where, if we were able to provide safe, healthy communities for low-income people, provide basically a middle-class existence there, not necessarily their incomes, but rather the communities they live in had everything that those of us who grew up in middle-income neighborhoods had, we would see a reduction in chronic disease over time.
Great. And I am just going to put one of your previous slides on the screen. One of our participants wanted to review again where they could find partnerships for local community development organizations. So I'm putting that up on the screen so all of our participants can see that. And I think this speaks to another one of our participants' questions is where do we go from here? So obviously this partner finder would be a great place to start. Do you have any other tidbits for people that are looking to get engaged outside of finding a partner from this website, giving them a call, sitting down and talking with them? Where do we go from here?
Any thoughts?
Yeah, that's a good question. I think the first step is to reach out, identify those partners, and set up some time to speak with them. But I also think that it would be good to think about larger strategy and intention. So what are some of those opportunity areas that you might be seeing? So maybe from a hospital or healthcare system side, what are some of the most pressing health issues that you're seeing And is there something that you see from the local CDC's investments or the CDFI's investments that really speak to addressing those health issues? And so maybe framing some questions or framing some ideas around that. But again, I think that's also something that we could support and we could help. So if folks on the line are feeling like not quite sure how to identify those areas or how to set up that agenda, we'd be happy to kind of support those efforts.
Mm-hmm. I would say too, I think it's an excellent question. I would say too that looking within your own health organization, whatever type of health organization you're part of, to see where there are opportunities for that organization to do more. We're really excited that just in the last few months, we've had Kaiser Permanente commit $200 million towards affordable housing. We've got the ProMedica example. The Dignity Health has been using that $120 million for, I think, 10, 15 years. They're one of the earliest. But my question always is, why isn't every hospital putting a small amount of its investment portfolio towards this type of work? It's worth remembering, and I'm on the advisory committee for the Dignity Health community investment portfolio, that $120 million represents a little bit less than 2% of their investment portfolio. So that's less than 2%. And this is, healthcare systems, insurers are another organization, another set of players who are incentivized to keep people in low-income communities healthier. If they use a few percentage points of their overall investment portfolio, that actually, the foundations have been doing this for a while, they call it mission-related investment, MRI. That $200 million from Kaiser, for example, is not being given away as grants. It is an investment. They will get 1, 2, 3, 4% return on those investments. These are low-interest loans that will be provided to neighborhoods, communities, and organizations that would be unable to get those loans from the traditional banking system. That's actually why this entire field exists, is because for-profit banks are not interested in what they perceive the risk to be. Institutions like hospitals, the idea of anchor institutions you probably all have heard of, really focuses on, in part, the role of healthcare systems to invest locally, to take perhaps a little bit lower return, but with the idea that it provides health returns in other ways. There's also an effort, part of the anchor institution model is to focus on hiring locally and buying locally. All difficult things to do, but all meritorious because they're part of the regular system as opposed to, it's not coming out of the Medicaid dollars or the healthcare dollars or all those dollars that are actually, that $1 trillion is not touched in that process. These are using other resources. So playing a role in your own healthcare system to talk to the CFO, to talk to the CEO, to the board about, is there an opportunity here to replicate or build on sort of the work and experience of other healthcare systems is a really powerful next step.
And I just want to ask one more quick question. I know we're at the top of the hour here, but one of our participants was wondering, as we're talking about community development and improving health outcomes of those in our communities, how can, a lot of times we're talking about urban and suburban communities. How can we take, and extend this approach to smaller rural communities that may not have as many existing resources?
Mm-hmm. Yeah, so just a quick response. That's a recurring issue. It's quite difficult. However, many people are thinking about that. At least two of the Federal Reserves, Minneapolis and Chicago, have done convenings in rural Wisconsin and rural Montana to focus on how these types of investments can happen. We actually have an essay in our Crosswalk magazine, two of them actually. One is focused on community development on Indian reservations, and the other is focused on rural community development that tries to answer some of those very questions. So it is more difficult there. The density is important, but there's a recognition that those communities are as important, and a lot of the worst health is happening out there. So there's a lot of innovations happening there, but we're relatively early in that.
And I would add that from the community development sector, there there is rural infrastructure to support community development investments and projects. And as an example of that, LISC, which again is one of the large national CDFIs, they have a series of rural offices across the country. So there are dedicated CDFIs to invest in and support. And that is on the Partner Finder.
Yeah, there's a rural LISC tab on the Partner Finder that is a good first step if you're in a rural area.
Great. Well, I just want to say thank you so much for all of our participants for tuning in to this installment of the Root Cause Coalition's How-To webinar series. And I want to extend a huge thank you to our two panelists today, Doug and Daniel from Build Healthy Places Network. Thank you all so much, and keep an eye out for an email from us when the slides and recording of this webinar are posted on our website. And I encourage our participants, if you have any questions or would like to follow up with Daniel or Doug, you can do so at admin@buildhealthyplaces.org. Thank you so much, and I hope you have a wonderful rest of your day.
Thank you.
Thanks. Bye-bye.